The curriculum advisory group, when we met with it, when we convened them, which included foster parents, felt it was very important for us to talk about common conditions among kids in foster care. Because, even though today we've been talking quite a bit about prevention and promotion, conditions is sort of a treatment-oriented question. You all have the answer to this question in your PowerPoint, but I was just wondering, has anybody not looked at it can answer this question for me? Why are we discussing conditions if we've been focusing on prevention and promotion throughout the day? Got one.
You've got to see what you're searching for. You have to know what you're searching for.
You have to know what you're, yeah, right, exactly. I mean, how do you know what a preventative? We don't know what it is, exactly. So, at some point you've got to say to yourself, well, these are some signs and symptoms that I need to be aware of. So this is a very quick and dirty, symptoms sort of overview of some common conditions. In the Casey Family Program's Northwest Alumni Study found that kids, particularly in Washington State, the highest percentage of kids that had a mental health diagnosis was found to be depression, and a very high number of also having post-traumatic stress disorder. So we're going to talk about those. We'll talk about bipolar disorder. All of you will probably hear these things often. One thing I'm going to try to do is dispel some of the language that you may hear in a therapeutic session or from a therapist or a counselor, because sometimes people just say words and automatically assume you know what they mean, and it may not always be that case. So we're going to go over oppositional defiant disorder, attention deficit hyperactivity disorder, and attention deficit disorder, two different disorders that we need to be aware of. Reactive attachment disorder, this is not in your Bright Futures material, but we'll talk about that more, because a lot of our kids, and I've even heard it brought up once today with Kristen's child, a lot of kids in foster care have this problem. And then post-traumatic stress disorder.
That list of all those disorders, in all the years I've been doing this, and I look at the referral sheets from the state every week on kids needing placement and all what they have. The first one about the depressive disorder, that surprised me. I hardly ever hear that, or that it's written down about the child. I hear all the other ones all the time, but no, I rarely have heard anyone say this child's depressed.
This child is clinically depressed?
Yeah, I never.
I should probably preface this by saying that the study that was done on kids who had aged out of the system, and found that, depression manifests itself differently at different stages in children's lives. So for early on, it could be irritability or withdrawal, and that might be generalized anxiety disorder, or that might manifest itself as oppositional defiant or whatever. So those things may get sometimes characterized differently, but it's interesting that you haven't come across depression. So major depressive disorder, page 271 of volume 1. You may hear the word dysthymia sometimes, which major depressive disorder requires that something serious has happened, and that coincides with around the time that you were feeling depressed. Dysthymia, well, let me ask, who here knows Winnie the Pooh? And, okay, so you all know Eeyore, right? Eeyore has dysthymia. Okay, Eeyore's just, I'm just a donkey, my life is terrible, I'm sad for no apparent reason. Dysthymia is that there's not is more of a bluesy. It's like depression light. So you may hear that from some clinical staff every now and then. It is not just a sad phase. It doesn't go away. And I think you might also be surprised to know that symptoms only have to be present for a 2-week period. I think there's a misnomer out there that you have to be really sad or hopeless for months or for a very long time before you can get that clinical diagnosis of being clinically depressed. But it really is only a 2-week period of feeling these things, and it has to be consistent over that period of time. You may see increase in temper tantrums. Again, this is all coping. This is all coping strategies to try to get their needs met. Reckless and destructive behavior. Somatic complaints. When I say the word somatic, what is that? Does anybody know what that means? Yes?
Physical issues, physical pain.
Exactly.
Stomach aches.
Exactly. Anything that manifests itself within your body. So they may complain about stomach problems, they may complain about headaches, they may complain about not sleeping adequately, they may complain of feeling, nauseous, all of those things. So you're the very first person to get that. Most people think it's sleep for some reason. Yes?
No
I don't see anything in here about lupus, and I know there's other illnesses that can cause depression, so isn't that important to determine between the physical and the mental?
The physical and the I mean, we were just primarily going over the symptomology of the mental illness itself. There is a lot of data to suggest there's enormous amounts of information that links chronic conditions such as lupus, such as diabetes, such as chronic obesity, even dental problems can cause serious problems in your mental health and stability. So that's something to keep in mind as foster parents in CASAs. And in your books, page 187, the bridge topics, you guys don't have to actually look at those now if you don't want to, but those do a great job of taking a look at each individual, each of those illnesses, and then relating them to other conditions that may come up. So lupus being one, that you may come across. Yeah. So somatic complaints, irritability, withdrawal, if you're hopeless or not feeling so great, it's really easy to feel cranky toward the world and not want to engage with other people around you. Hopelessness, boredom, emptiness, loss of interest in activities. Page 273 of volume 1 for bipolar disorder. It's a roller coaster of emotions, so you're going up and down all over the place. It goes along with having a labile mood. Who knows what labile means? Okay, another one of those terms that, yes?
It's like instability.
Yeah. It's not the intensity of the mood, it's that your mood goes all over the place. You're sad, you're happy, you're hopeless, you're content, so it's sort of your mood itself bounces all over the place. Then you go to irritable and euphoric. So it goes up and down, up and down. I've always said that if I wanted to either have depression or bipolar disorder, I'd much rather have depression because you always know where you're going to be. My patients at the hospital on the weekends, those that are bipolar, it takes a lot of energy to do the up and down constantly, to go to manic and feeling really energized to all the way down to feeling really down in the dumps. And it takes a real toll on someone's soul. Aggressive outbursts, so yelling often is associated with it. Fluctuation of mood. So that's the intensity of the mood that you feel. You might feel terrible one second and then feel really bad the next. Reckless behaviors, dangerous play, inappropriate sexual behaviors. And again, those are all trying to cope with going up and down and all over the place. Agitation, pressured speech, and again, one thing I want to caution you about is that some of these things may just be developmental. How many of you know a teenager who talks 1,000,000 miles a second, like on the phone? And so that's not pathological. That's not a disease. We just need to make sure that it goes within the context of the other things that we're looking at. Illicit activities. Illicit meaning criminal. So if you hear the word illicit used about your child, it means that they've engaged in some kind of crime. So again, also something trying to cope with what's going on with them. And then psychotic symptoms. The word psychotic has been used to refer to, mothers-in-law or pets that are just not house-trained or just, other things. Who can tell? But psychosis has a real definition. Can someone tell me what the definition of psychotic or psychosis is?
Different types of hallucination.
Yeah, I mean, essentially, you are experiencing a reality that is not real. And there are two kinds. There's hallucinations, which can be either auditory or visual, so you can see or hear things. And then there's also delusions. So something that can actually be happening, but most likely is not. So hallucination would be, you're hearing something, but then a delusion is there's been a microchip implanted in my head that's transmitting information to the KGB. I've heard that one before. It's probably not happened, but it's a belief. So you can think of the differences between something you're seeing or hearing and a belief you may have. Now, something else to keep in mind is that sometimes in our political climate or in our current climate, there are sometimes things that hit the news that may make people feel like they may have, and they may say something that sounds somewhat delusional, but it's not. For example, I was listening to NPR the other day, and this woman who has a client in, I think it was either Jordan or Syria, and has been having ongoing conversations between herself and her client, fully believes that that she has had, her conversations, her phone records have been given to the federal government. Now, because of what we know from the USA Today article and other things, we know that that's probably true. But if you meet somebody on the street, or potentially true, if you meet somebody on the street and they say, "Oh, I am being watched by the federal government," you're going to just automatically think they're psychotic. But just to keep in mind that they are not necessarily, you have to consider the current climate and news of what's going on. Oppositional defiant disorder. A lot of you guys will hear about a lot of this. Page 293 of Volume 1. You may hear conduct disorder, antisocial personality disorder. Conduct disorder essentially means that they've committed a crime, and that so now they get disordered. They get a disorder because of it. Antisocial personality disorder. It's kind of the DSM-4's way of DSM-4-TR. It's a way of trying to diagnose people who have sociopathic or psychopathic tendencies. It doesn't do a very good job. It doesn't always go well together. But it's essentially somebody who doesn't really feel a whole lot of guilt about fulfilling their own individual needs and desires. So doing whatever it takes to get their needs met. You have a question? Yes, sorry, Diagnostical and Statistical Manual of Mental Disorders. It's been revised several times. It's sort of the Bible of mental health. So yeah, if you really want to put yourself to sleep, put that by your bed. Maybe very rebellious and or argue often. Who's had teenagers? This is not pathological. This might be developmentally appropriate, because what two things do people need or two things that kids are trying to negotiate when they're that age? I'm trying to, one, assert my independence, and two, my peer culture becomes very important. Therefore, you don't know as much as I do, okay? May intentionally annoy others. It's kind of a telltale sign. So are we there yet? Are we there yet? Are we there yet? May blame others for his or her mistakes. Again, trying to put off receiving punishment. May have severe arguments, may be defiant and unwilling to compromise. Again, may not necessarily be pathological. It may just be developmental, so that might be something to keep in mind. It's when that kind of rises to their being really, really out of control with unwillingness, and they won't listen at all, period. May precociously use alcohol, tobacco, or drugs. And by precocious, I mean using them from an early age. So this is one of those telltale markers. If you have a child who's using drugs or engaging in sexual activities at the age of 10, 9, 11, you may have an ODD child, but again, you have to consider them within the ecological context of what's going on with them. Adjustment disorder, not in your book. It's short term, so sometimes what happens is these things eventually grow into a full-fledged diagnosis. You may start out with adjustment disorders with depressed features or anxious features or manic features, and then if it doesn't resolve itself, it eventually turns into a full-fledged diagnosis of generalized anxiety disorder or depression or manic, bipolar disorder. It usually occurs within the 3 months of the stressor, and the stressor cannot be a death of a loved one. It's normal for kids to feel sad when they experience the loss of somebody. So we certainly don't want to attribute that to adjustment disorder. So if the child, we're not trying to do with Bright Futures is to say all kids should be happy every single moment of every single day. What we're trying to do is to promote their coping ability to deal with a variety of emotions that they may experience. And they're supposed to feel sadness. They're supposed to feel joy. They're supposed to feel all of these things. And once the stressor goes away, the child feels better. So who would agree that being in foster care, period, just getting removed from your home is potentially a stressor? Yes. Yeah. So for some of these kids, does the stressor go away? Not really. Yeah. So it's chronically being chronically being close to the stressor.
If a child gets moved several times within several months, is the effect just cumulative, or is it multiple?
So the question,
Multiplier.
The question was, with children being moved from month to month, is the effect cumulative, or does the effect happen per foster home? Is that what you're saying?
Does it happen in, like, the first time it happens, it affects them 10%. The next time it happens, it affects them 20%.
Oh.
Or is it, does it get multiplied each time?
Is it exponential?
Yes.
Okay. That's a wonderful question, and unfortunately, I don't necessarily know if we have the direct answer of that. We do know that the more placements they have, the more their mental health breaks down, but I don't think that there's an exact formula yet to identify. And it also is based on, in my opinion, I could be going out on a limb here, is the individual resilience of every child. You will probably have come into contact with different types of kids, and each one of them has their own ability to cope or be resilient in their particular environment, and some of them don't have those coping skills. So it would be different, I think, in my opinion, for every child who goes into a variety of different homes. In my experience, that's kind of how it goes. But I'm not sure what your experience has been.
Now that I think of it, I guess it depends a lot on the situation of who the child is, what their character is, and the character of the places that they go.
Mm-hmm.
You know,
yeah. So there's a lot of factors that influence whether or not a child, based on the placement. So, but a great question. ADD, ADHD. This is the fun one. There are two issues, page 203 of Volume 1. There are two issues that are associated with attention deficit disorder and attention deficit hyperactivity disorder. One is the inattention or inability to pay attention. The other one is their hyperactivity, or they're bouncing off the walls. They're going all over the place. So one is that, kids in general, there's a distractibility issue, but it's only when the distractibility causes a significant problem. Most of the time kids before they go into academic settings, it's not really an issue. But when they have to go into school, that's when it becomes a problem, and that's when it's picked up on. Misses instructions in school, gives up on tasks, misses subtle social cues, so they're just not quite getting it. Hyperactivity, runs into people and things, can't sit still. Well, that's me. So again, don't pathologize these things, because these things can just be a regular part of development or part of an internal personality. Intrusive, interrupts others often, getting in front of people. Yes, question?
How can you tell the difference between the adjustment disorder and ADHD initially, because they seem to manifest in parallel ways?
That's a great question. Well, the similar manifest is that...
What was the question?
The question was, how can you tell the difference between attention deficit disorder and adjustment disorder? Because it both seem to manifest in very similar ways. They look the same when they're coming out. And adjustment disorder, if it has sort of those manic features of up and down, especially with the mania, you're going to have things that go all over the place. There's one is that attention deficit disorder does not have one particular diagnostic tool. There are multiple diagnostic tools for attention deficit disorder, so that is hard to say. And adjustment disorder also doesn't have very many diagnostic tools. So the thing for both of them is time. Attention deficit disorder corrects itself with medication and other stuff and doesn't necessarily go away. Adjustment disorder is supposed to go away. So that's the one difference. But in the beginning, it's very hard to tell, and you won't be able to adequately identify what it is versus what attention deficit is versus adjustment disorder right away sometimes. Because mental health, unfortunately, as much as we really try to insert science and good research into mental health, a lot of it is still in art form, and then it's sometimes really hard to identify. These symptoms may lead to this criteria, but they are not necessarily, they don't necessarily lead to this other one. But it may be, in fact, that's what's going on.
I had a child in my home who they thought was this, and the medication that they used made him even bounce off the walls worse. And so what I guess I was wondering is, can bipolar or other disorders also have the hyperactivity attached to it?
Yes.
Okay.
Bipolar disorder, especially with the mania, when you have a child who's going way high up here and all over the place and has a burst of energy, absolutely. It's hard because a lot of times I've seen psychiatrists, they'll they won't say, oh, this is exactly the medication you need. They'll usually say something like, let's try you on this and see what happens. It's more of an experiment because everybody's going to react differently. Everybody has different body chemistry. So yeah, that absolutely does happen.
Yeah, I wanted to ask you about the conduct disorder. It looks to me like that's a stage.
Potentially. I mean, it's an interesting one because it's the only one that's sort of like committing a crime as a diagnosis. So it's kind of a funky one. I'm not really.
And it also, it's sort of, well, the reason I'm curious about it is because it really fits my client. All the characteristics fit what my client is going through right now more than any of these other ones. And so I'm thinking that it may be a stage and it's also sort of situational, you know?
Yeah.
Rather than say something that's necessarily going to be chronic the rest of his life.
Right.
Right. Does that sound like a fair assumption?
Exactly. It might be a developmental thing. Okay. Remember earlier that I was saying that one of the two things that you have to negotiate when you're an adolescent is, one, establishing your independence, which means resisting authority figures and doing whatever it is that you want to do. So sometimes that might be taken to an extreme. On the other hand, sometimes a conduct disorder diagnosis will actually get you the services that you need. So it's sometimes okay to have those labels. Unfortunately, we'll talk about labeling in a little bit. Yeah.
Are there guidelines as to when you might start to see some of these, like bipolar disorder? I mean, certain ages, that like 4 years old, 10 years old?
I see what you're asking. You're asking about the age of onset, like how early can you diagnose? I've heard of 6-year-olds being diagnosed as being manic depressive at the age of 6. It's kind of young. In my opinion, I usually think that that's, especially with the energy level of a 6-year-old, probably going to be something more developmental. We tend to, in psychiatry, I know psychiatrists tend to try to shy away from giving diagnoses at such an early age, but it really is based on the individual psychiatrist. And sometimes there are kids at young ages who do really need services and interventions. It's kind of inconceivable sometimes to think that a kid that age should have a diagnosis. Attention deficit, I think the average start is about 7. Yeah. Okay, fooling around. Reactive attachment disorder, not in your book, kind of ironic. And it's interesting, in the DSM-4, it actually says in the book, is really prevalent among kids in foster care. So the whole notion is I'm going to reject you before you reject me, which kind of happens when you have kids bounced around all over the place. I don't know why, but when I was a social worker and ever I had a rad kid, reactive attachment disorder, they like to smear things on the wall. I don't know why, that's one of the telltale signs that I noticed. Failure to initiate or respond in a developmentally appropriate fashion to social interactions. So, at a birthday party, they're the one to run and hide in the middle of a room, or start beating up the other kids, or whatever. And then diffused attachments. When I say diffused, I mean that they are literally can attach to anybody, anywhere in the room. They are no more likely to go attach themselves to Uncle Joe than they are to you. So that's a real marker of reactive attachment disorder. And if it's not caught early, it can really develop into some serious problems later on. So the best thing to do is to try to work with somebody, when a child is fairly young, because I haven't heard good stories of kids who are reactive attachment disorder and then are in older, when they get older, it just gets worse. Yes?
With that the one you just mentioned, diffuse attachment.
Yes.
If you see that a kid it's obvious that the child has this, a young kid. Because I'm thinking of one that I had before. She was eventually adopted, but we're talking 3 years old. Now, if you see that, what can be done? Because I know in the case this was one of my first cases, years ago, and I'm not sure, I don't think anything was done. She was fostered off of the relative placement, that's it. She's out of the system and all that. What can be done? Family therapy. Therapy that emphasizes the relationship between a child and a particular adult. Have any of you heard of the field of infant mental health, which is,
quite fascinating too. There's actually a Center for Infant Mental Health here in Washington State at the University of Washington, which the whole movement is based primarily on that the attachment between a caregiver and a child is so strong that it can really influence a child's mental health. So one of the things, reactive attachment disorder, would be, like, one of the things that infant mental health looks at seriously is the attachment between the caregiver and the child. So any infant mental health specialist or any other specialist can provide skills to the parent on how to build that relationship and maintain it despite having a child who is reacting to not wanting that attachment because I feel like you're gonna let go of me so I'm gonna try to keep myself safe by rejecting you, you know. But it's an intense disorder.
This is an effect. I'm concerned about causality here. I can see where simple movement of children would be, but something like sexual abuse or severe physical abuse or emotional abuse might be a causality here.
Right, where a family member was not able to adequately protect a child, so the reaction is to the... I've seen actually a lot of reactive attachment disorder in kids who've been adopted abroad, especially from Eastern European countries, because of the conditions that they were in beforehand, where they were in an orphanage, that they weren't really particularly attached to anybody. In terms of causality, it's all over the map. You know, we don't necessarily know exactly what causes it per se, but there are linkages between mostly abandonment, mostly feeling like you're being moved from home to home. I'm not necessarily sure about the sexual abuse and the child abuse sort of connection, but it could very well be there. Post-traumatic stress disorder, page 194, volume 1. It's essentially reliving the trauma or whatever it is that you've gone through and the prior trauma that is causing you to feel distress now. Kids may have distressing dreams, not based on just watching Harry Potter or something else. And re-experiencing trauma through play, drawing, and storytelling. So they'll be talking about it, they'll be drawing it, they'll be playing it, they'll be modeling it in their Play-Doh, they'll be using sand trays, that kind of stuff. So be aware of how they're playing sometimes. Physical, somatic symptoms, we talked about that already, especially associated with the type of trauma. Increased hypervigilance, so increased awareness of what's going on around them. Always, you know, kids who may have a serious startle reflex, so if you hear a loud clap, they jump. Okay, that's hypervigilance. And then avoidance of activities associated with trauma. I have a very close friend who was in Argentina for a couple of years, and she was mugged there, and her purse was taken from her. When she was in San Diego with us a few years ago, and we were walking down the street. She was with her parents, and there was somebody walking behind her, and that's how she was mugged. She immediately stuck her back up against the wall and just stood there for a moment. And her parents were wondering, well, what's wrong with you? Why are you stuck against the wall? She's like, I have no idea. I just don't like people walking behind me. So, you know, tendency to avoid activities that are associated with that kind of trauma. When to seek help? When you see many of the symptoms in the book, not a few, not some, but you know, and it's also the severity of the symptoms. You know, if something is causing a serious interference with your ability to live your daily life, please get some help then. Suicidal thoughts, that's a life or death issue, and it's best to, you know, when in doubt, contact a professional. Psychotic symptoms, if they're hearing voices or seeing things or having delusions, it's very, very scary. Working with patients, I will tell you that I have never had somebody who has said, the voices are telling me I'm pretty. The voices are telling me nice things. They always say mean things, like you're mean, or you should jump off a bridge. I don't know. I really wish that we could figure out a way to make the voices say nice things. Disturbances in sleep, weight, or activity levels that impact functioning. If you've got a kid that won't get out of bed for days at a time, that's something to be concerned about. Oh, whoops. Health risk or delinquent behaviors if your child is being promiscuous or doing drugs or engaging in crime. Please get help. Strong family history of psychiatric illness, only with other symptoms. You know, automatically kids will not have the genetic makeup of their parents. So you don't want to assume anything, but if there's a strong family history, it's important to keep that in mind. Stigma. There's not a whole lot of information in here about stigma, but we felt like it was important to talk about it. Many people are uncomfortable with labeling, and rightfully so, especially when you've got, you know, like 6-year-olds and 5-year-olds who are having bipolar diagnoses. It's kind of hard to deal with that. Many are afraid that they'll get drugs pushed onto their kids. I will tell you, in this state and every state, you are not allowed, your child is not allowed to have drugs without your permission. So just to keep in mind. And mental health law, it's actually over the age of 13. They have to consent to it themselves. Different kind of treatment. I don't want my kid treated differently because they have this mental illness. I don't want people to talk to them in a different way. So, that's something else to keep in mind. Self-fulfilling prophecy. If you give my kid this diagnosis, then they're going to act like this. For that one. And the double stigma of being a foster kid and being mentally ill. So not only am I in the child welfare system, but I'm also labeled as crazy. One thing I want to talk about in terms of labeling is not necessarily labels are, we don't like labels. We don't like being put in boxes. Sometimes we need the labels in order to get adequate services, and sometimes we don't necessarily need them. It's good to think of them on an individual basis and identify what's going to help my child versus what is not. Is it going to be okay to label my child depressed when it's not really going to help him or her do much of anything? So that's something to keep in mind. And it is a disease just like any other. Diabetes, cancer, obesity. I know that I have to exercise 4 or 5 days a week. Otherwise, I feel terrible. So I know that I need to do that for myself, and that's not considered a stigmatic thing for me to do. But it is sometimes considered stigmatizing for someone to take their antipsychotic medication, or to go to therapy. I mean, those are things that are sometimes felt like, oh, well, this is not good for you. I think it's because a lot of people feel like mental illness is the fault of the person who has it, and that they can do something to control it themselves. And whereas cancer, it's not your fault, You did something, you didn't do anything to deserve this. More information, page 187 to 338. There are some things that we didn't talk about today that some kids in foster care may experience, and those might be things like eating disorders, panic attacks, learning problems. There's a real high correlation between eating disorders and sexual abuse, so that might be something for you to take a look at. There are also some information on chronic conditions and its relation to mental health disorders.